Thank you, and thanks for asking me to do this. I hope I answer the questions that you're looking for. I focused a lot on methadone and Suboxone, but certainly would be willing to answer any questions people have, and have really liked the opportunity to come to the ICU and see patients there. I've really found that very valuable at both sites. So as I always like to have, I don't have any conflicts of interest. No pharmaceutical company has found me and paid me not to talk. I have, not all of these patients died in the ICU, but certainly I've seen a number of patients that have died of infectious complications of injection drug use, and I think that doesn't get enough mention, so I like to dedicate this to them. A Coles Notes version of the opioid crisis, I just thought I'd just mention, I'm sure this is all old, but we often focus on the prescription opioid crisis, leading to 1/8 of young adult deaths, 1 out of every 170 people in Ontario, and particularly looking at lives lost. There are, compared to even alcohol use disorder, if you look at years of lives lost, there's more people with alcohol use disorder, but the years of lives lost are probably the most in opioid use disorder. But everything and all the numbers, and this has been a struggle I've had, are only about toxicity. So anything that we're dealing with the opioid crisis, even now during COVID, there's a lot of talk about overdose, and people with infectious complications of drug use are not counted. I talked to the Chief Coroner of Ontario, and he said that he would be interested in starting to count them. And I think Karen Bosma was on and called the coroner for the next patient who refused to come. So in London, we can't get them to mobilize. We also looked at the deaths. We found that in London, that the number of people who die from infectious complications of injection drug use is at least equal to the number of people dying from toxicity, and might be as much as 2 times higher than the number of people who die from toxicity. The only other thing I'll mention is that when people die in the street, they don't do an autopsy. So if somebody dies of septic shock in downtown East Side, they are listed as a fentanyl overdose. And essentially the same happens in London too. So it's hard to even know for sure how many people are really dying of toxicity versus an infectious complication, because outside of hospital, everyone is assumed to be pretty well to be dying of toxicity if they've injected. My experience in London has been, and I think this is consistent with downtown East Side, but that injecting prescription opioids causes more infections than injecting illicit drugs, and particularly by that I mean heroin and fentanyl. This is probably old news, but certainly our public health unit has declared a public health emergency in 2016 of infective endocarditis, HIV, hepatitis C, and eye gas. The first 3 are definitely directly linked to injection drug use. The 4th, eye gas, was a little more complicated and not always related to injection drug use. London and you are working in the epicenter of the storm. We have a higher number of injection drug users than Toronto. That's not percentage, that's number. And a higher or as high or higher percentage per capita of drug users than Vancouver. So if you look outside of downtown East Side and all of Vancouver, we have a higher per capita number of people injecting drugs in London. Certainly I want to mention that adverse childhood events increases the risk of substance use disorder, and certainly many people come with trauma. Some of that trauma is related to healthcare. Having said that, London does not have a higher percentage of people with adverse childhood events. What we had a high amount of was prescribing opioids, but many of the patients you will see do have trauma. And certainly I think there's significant, particularly since the Truth and Reconciliation Commission recommendations, an understanding of a need for cultural awareness and sensitivity and competency. There can be intergenerational trauma within our Indigenous people. And as you probably know, there's now an Indigenous Healing Center that's open at Victoria Hospital. I haven't quite figured out how people at UH are going to access it. And I'm not sure that that's going to be relevant to most of your patients, certainly not while you're taking care of them. The ICU CCTC presents a really interesting and very specific, unique problem. And that is that you aren't always able to get a history. Most of the people come in with a decreased level of consciousness. And it's very common for witnesses either not to know what people were taking. They're afraid to answer if they do know. And our witnesses are often very unreliable. I know of a case of a young woman who at 25 died of a fentanyl overdose. I know the people that were involved when she overdosed. When she presented with seizures, nobody commented on her fentanyl use, and nobody in the ICU took a urine drug screen. So witnesses aren't always reliable. The other thing is that certainly right now, at least in theory, what people are taking, they don't even know. There can be benzodiazepines in fentanyl. This can certainly affect whether naloxone is going to be successful as a form of resuscitation on its own. And patients don't necessarily know what they're taking. So since I have an audience, I'm going to probably do a few slides. One of the things I would hope to see more of are urine toxicology screens. I think somebody gave a talk, and it was before I started doing addiction work, so it was before 2012, saying they're not useful. They might not be useful in the emergency department to make a decision, but they're extremely useful from my perspective for caring for patients in an evidence-based way. And I find that we don't do enough of them. If any are positive, they keep them for 6 months. If they're not positive, they throw them out pretty soon, certainly within 48 hours. So from my perspective, anyone with a decreased level of consciousness, possible substance use disorder, injection drug use, seizure, if not a known history, an odd presentation, a young person having a stroke, I think we need to do a urine drug screen. And for many reasons. One is the drug they're taking contributing to their presentation? Are they taking what they say they're taking or think they're taking? A lot of times I'll have residents say things like, well, they told me they were using, crystal meth, so I didn't bother doing a drug screen because they're being honest. People often disclose parts of what they're taking for various reasons and don't always give a full picture, and some of that picture can be really relevant. The other thing is sometimes we repeat, if we see changes in behavior when people get to the floor, we'll repeat a urine tox screen. If it was negative when they got there and positive, a week later, it's pretty easy to say that they've now been using, as opposed to it's continued in their system. But to me, the most important reason is whether it's going to interfere with drugs that we think they're on. For example, if somebody's on somebody's on methadone and they're also using cocaine, it actually will mean that the methadone dose that they're receiving in the community has been altered because cocaine is an inducer. So they're not getting their full dose of methadone essentially, which is really important to know if somebody's lethargic. If somebody is getting their dose that they are getting at home, but seem to be really lethargic, it's good to know whether they were using a stimulant or not. So cocaine is an inducer, but all stimulants will affect the presentation of an opioid. So, and it doesn't matter the route. So if people are using crystal methamphetamine or Ritalin, it will certainly affect the manifestation of their opioid use. And by just getting the opioid, they will present as more lethargic than they would in the community when they're taking both. And people can be withdrawing from more than one thing. I see a lot of I think, missed benzodiazepine withdrawal, partly because by the time the urine drug screen's done, they might have already received a benzodiazepine. It's certainly not a withdrawal I'd want to be missing, but people need different treatments for different types of withdrawal, whether it's opioid. Cannabinoid can give a very significant withdrawal. Obviously alcohol, but that hopefully isn't missed very often. The other thing to note is opiates. Doing a urine drug screen at LHSC, getting an opiate response that's negative is essentially meaningless. Our opiate screen is only for morphine and codeine, and not many people are using either. It can miss hydromorphone and oxycodone, and it will miss fentanyl and methadone. There is an Emerge urine drug screen specifically that includes fentanyl, but most people don't use that one, and it's not done a lot. And since really the drugs of choice from an opiate perspective of abuse in London would be fentanyl and hydromorphone, they're missed. I think that I want to focus on opiate agonist therapy for a few minutes and just discuss how important they are, because I feel like this is an area that's not discussed enough, and I think all residents and physicians need to have a good competency with understanding opioid agonist therapy. They are certainly an important form of medical management. They are life-saving. If they're discontinued suddenly, they can be, it can be very dangerous. Even withdrawal can be extremely dangerous. And they can be used either for recovery or for harm reduction. Methadone is long-acting. It's a full mu agonist with variable half-life and is usually used once a day. Oops. It's a harm reduction philosophy. Many of the patients we see are using methadone as a form of harm reduction. So by that I mean they're on methadone, and it means they're using less drugs in the community, but not none. But it's, when I got trained in methadone, I had the opportunity to work at Clinic 528 and was quite pleasantly surprised at how many people that they see that are using methadone exclusively for recovery. I started at 7 a.m. and I thought I was going to see the people that were up all night. What I was really seeing were people that were heading to work and coming in to have an appointment before they got to work. So there are certainly a huge number of people in our community that are using methadone as a form of recovery, but there are also people using methadone as a form of harm reduction. Most people on methadone, well, I don't know if the words most, many people on methadone aren't able to get off of methadone. It can be a lifelong treatment. It depends on how long they were using opioids before they went on methadone. If they're young and it was a short time, they'll get off. If they've been on for years, it can be a very challenging to taper off of methadone successfully, and there is certainly a risk of relapse and overdose. In the ICU, you have the ability to do something that we don't do enough in the community, which is assess the QT. Methadone reacts with a lot of drugs, prolonging QT. Sometimes people are admitted because they went to a walk-in clinic and got, Cipro, and it prolonged their QT, and that wasn't even known by the physician prescribing. So in the ICU, that's an easy one. But as far as what to do with methadone in the ICU, it's much more complicated than I think people are aware. The pharmacist will phone and find out from the pharmacy what the last witness dose was. That is something that you have to have verified, and generally speaking, that happens by pharmacy. But that is a small, tiny part of the story you need to be able to be able to prescribe wisely. You also need to know whether people had take-home doses. So some people might have their last witness dose 5 days before they were admitted, and they have, or maybe even 3 days before they were admitted, and have 7 take-home doses. And there is no way of knowing whether they've taken any of them or none of them. So that can be extremely relevant. But the other thing that's really relevant that gets missed on admissions on a regular basis is whether the last home dose was actually reflective of what they've been taking for a while, or just that they were not compliant with treatment. So I'll see an awful lot of people who are admitted on 30 milligrams of methadone. But if you actually go back to even maybe the week prior to their admission, they might have been on 90 milligrams, but missed 4 days and were restarted at the beginning. And in hospital, we have the opportunity to put them back, or to put them on an appropriate dose if we know what it is, not necessarily immediately in the ICU, which we'll talk about, but the last witness dose is only a very small piece of the puzzle. It's also, as I mentioned, really important to know if there are other illicit or prescribed drugs that will affect the metabolism of methadone. If methadone has been missed for 1 to 2 days, you can continue on the same dose at home if there's no decreased level of consciousness. If they've missed doses for 3 days, we decrease the dose by 50%. But that's with no decreased level of consciousness, which to me is not going to be many of the people you see. They say if they have take-home doses that aren't witnessed, we don't have a way of knowing what they're taking or whether they're diverting. So we have to be really cautious. People with take-home doses, that means that they're potentially doing well, but there's no way of verifying exactly what they've taken. So in the community, if somebody has a decreased level of consciousness, they wouldn't get methadone for the day of admission. But stopping it altogether, particularly in the ICU, could lead to significant withdrawal. And certainly a problem with restarting before they leave. So generally speaking, kind of as a guideline, I would be suggesting decreasing by about 50% of their home dose, assuming that they've had something near to the time of their admission. If they've missed 4 days or more, they're essentially a restart. So if somebody has not been on methadone for 4 days, then we do restart at 20 to 30 milligrams. But that's not necessarily the thing I would jump to fast, because really it's a restart. It doesn't matter what day you do it, it's going to be a restart. So when you have people on other opiates, it's not necessary that they start on methadone. And this might be an excellent opportunity to be switching people to Suboxone, especially if they're admitted with toxicity or overdose, whether it's accidental or intentional, or complications of respiratory illness, or anything in which really methadone might need to be reevaluated, as whether it's the best first line at this point. So I will see people that have been off their methadone, and by the time I'm called to see them, they're restarted on their methadone. It just makes it significantly more complicated to do a Suboxone start in that case. Having said that, there's a few things. If we have dose reduced in the hospital, then we have to be looking at whether we need to increase, particularly as they're coming out of the ICU. We can increase by 5 to 10 milligrams every 3 days. In the ICU, we can do it faster. So if we've guessed wrong, somebody had take-home doses, they've been compliant, and their methadone isn't at all part of why they were admitted, and we dose reduced by 50%, we can continue to go back up. If they're now wide awake and experiencing withdrawal, we can increase them faster. And if they've only missed their full dose for less than 3 days, we can actually put them right back on their full dose. Having said that, we also might not need to put people back on their full dose. If they were using a stimulant in the community and we're not giving them their cocaine in hospital, they may never need to go back on their full home dose. And if they weren't taking their carries, there's a huge market for methadone. So if they weren't taking their carries or taking them as prescribed, they may never need to go back on their full dose. People who are diverting rarely tell you. Sometimes when I give them the science and explain why it doesn't look like they were likely taking what they thought they were or felt they were taking, they will disclose. But it's a high income that they have to give up if they disclose. So we do have to watch for the clinical response. Suboxone, I hope people are becoming much more familiar with Suboxone. I will do starts of both methadone and Suboxone for people admitted to hospital with opioid use disorder. Suboxone is really essentially considered first line now, but it's a little hard in the ICU. So it's a high affinity partial agonist. It decreases the risk of toxicity from other opiates, and that word's out. So there are a lot of people on Suboxone now that know that if they use fentanyl, they're less likely to overdose, or if they're using Sublocade. So there are definitely people who are on Suboxone with the expectation it's protecting them from an overdose, but are still using. I used to consider Suboxone more like a recovery and methadone more like just harm reduction, but there's recovery and harm reduction in both populations. If possible, Suboxone should be continued. This can be challenging in the ICU because it is Suboxone itself is only sublingual. It's not oral, so it doesn't do any harm if you give it through an NG tube, but it's only about a third absorbed. So the recommendation would be to continue it. And somebody who could use sublingually. We use it because it's safer. There is less potential for abuse. There is less potential for diversion, but not a lot, in that there is a good market for Suboxone too. All physicians can prescribe it. It still pops up as a tier 3 drug at our hospital. I don't know why, because it's not a tier 3 drug in the community. I've mentioned that to Drug and Therapeutics Committee, but they haven't changed it. And all physicians who are licensed can prescribe it. I mean, it's best to have training. But I think right now at LHSC, I certainly know if a resident puts in an order for methadone, it's not processed and it just stays in a state of waiting for their consultant to activate it. The pharmacists don't see it, so they do not know that there's a waiting script, and sometimes are not aware that they should be looking for their methadone doses. I think it's the same for Suboxone. I'm not 100% sure whether residents can prescribe it. I'm not quite sure I understand that, but I think it has to wait for a consultant to activate the order. So just looking at the difference. So as the dose of the buprenorphine, so Suboxone is buprenorphine plus naloxone. As the dose of buprenorphine increases, you don't increase your risk of respiratory depression in the same way you do with all other opioids, including methadone. Same thing with people in the ICU. You do need to verify their last witness dose, the number of take-home doses, and determine if there's been any change in recent doses. If somebody has been in the ICU but has regained consciousness within 5 days, it can be started. I've certainly seen people who've been transferred to the hospital and nobody's restarted their Suboxone. So even if you put them on hydromorphone or any other opiate, as long as they haven't been off their Suboxone for 5 days, it can be restarted, even right back up to the original dose. But the other thing to remember is if it stops suddenly, they become more at risk of opioid toxicity as it wears off. So it does have a protective effect. If it's not restarted, the same dose of an opioid could become more toxic to them as the buprenorphine is wearing off, particularly at about the 5-day mark where it's essentially considered worn off. So it's just something to recognize if that we may need a decrease or a modification in their other opiates when people are on Suboxone as it's wearing off. Same thing with Sublocade. I mentioned, okay. So Sublocade is the injectable buprenorphine that's now being used in our community, particularly at the Rapid Access Addiction Medical Clinic. We probably have the pioneers of Sublocade in the world, certainly in Canada, and have among the highest prescribing of Sublocade in this area. So it's injectable buprenorphine. It can be used in anyone using up to 8 milligrams of buprenorphine or higher, and technically it lasts 4 weeks. You should go in every 4 weeks for an injection of the Sublocade. It's in the system for about 4 to 6 weeks. Again, it's protective of toxicity, and can be wearing off as people are in hospital, which I don't think in the ICU it's going to likely be an issue of giving Sublocade, although it might come up. But certainly it could be wearing off, which can have effect during a prolonged ICU stay. This is being recorded, so I'm going to be careful of what I say in this next area, but there is something called, referred to by the people prescribing it as SAFE or Safer Supply Program, which is primarily used at London Intercommunity Health, but they have been promoting it widely, so there could be other people who are also feeling that this is a benefit. It's based on a Vancouver model of harm reduction from fentanyl overdose specifically. So what it is prescribing mostly hydromorphone, so Dilaudid, immediate release Dilaudid. Sometimes people are also on Cadian, so the long-acting morphine. Occasionally they're on other things like hydromorph-cotton, but the vast majority are on, or prescribed, I should say, hydromorphone. It is not a witness program. They don't have a day that they witness all of their drugs. There is absolutely no way of knowing at all how much people are taking. And if there's one thing I can say is do not think that they need to be reconciled to their quote home drugs if they're on this quote safe supply program. You might recognize it by somebody who's on somewhere between 12 and 20 Dilaudids, and they're getting them dispensed somewhere between 1 and 7 days, and they have a physician or a nurse practitioner from Intercommunity Health. The vast majority of people that will end up in hospital are likely diverting. And in my, even if they're on other drugs, fentanyl or other drugs, it certainly can affect what their dosage is. So a lot of people are selling all of it and taking fentanyl. They're selling it and getting their crystal meth. You cannot use the dose as an accurate portrayal of what they're on. The other thing I think is really important to mention, particularly if people are working in Emerge, I am seeing a temporal correlation that I'm trying to work to prove as a causal correlation between injecting Dilaudid and osteomyelitis of the spine, epidural abscess particularly. I've never seen more. Many of the people I see have shown up in Emerge a few times before they're diagnosed with their epidural abscess. So if people are injecting Dilaudid, I think it's just something we have to be thinking of more. If they're injecting Dilaudid and a stimulant, it increases the risk. I didn't see it when people were injecting stimulants with hydromorph-cotton. We saw mostly just infective tricuspid valve endocarditis. I think the thing that's really changed in our community is injecting the immediate release Dilaudid, and I think it's causally, but as I say, at least temporally related to the program. So it's just something to be aware of. I also see more septic arthritis, necrotizing fasciitis, and more left-sided infective endocarditis, although prior to hydromorph-cotton, infective endocarditis seemed to be 50-50 left-sided versus right-sided, and I think that's what I'm seeing again, which when we had so many right-sided, that just makes the left-sided look a lot higher. As I mentioned, don't assume compliance and don't reconcile them to their home drugs. What I usually do with this population is think of it as a 50% dose reduction. That may or may not be relevant in the ICU because often you're using their parameters for how you determine what you're using with hydromorphone. But certainly, as I mentioned, don't assume that they're taking it. I start people in the community on about a 50% dose reduction and then increase or decrease depending on their TAU score and clinical response. So far, I've had one patient, well, maybe I'd say 5% of the patients are actually taking a higher amount than is prescribed when they're taking their prescribed drugs in addition to, so fentanyl, so they might be taking illicit drugs or other prescription opiates in addition to what they're prescribed. But the vast majority of people I'm seeing are using significantly less, often 25% of what is prescribed. I haven't had anybody taking no opiates, but that's actually even a possibility. Again, at discharge, I wouldn't be reconciling them to this is more relevant on the floor, but it shouldn't be reconciled to their home dose. They should be reconciled to what we're giving them in hospital. That might be changed when they get back into the community. But I think it's really important for us not to be specifically creating diversion as a plan. There are reasons why people think that's okay, but I think from our perspective, that's not something we should be doing. I didn't mention as much about other people who come in on opiates. I think it's always cautious about what we're giving. I know in the ICU you use IV, and I think that's always a good place to start. It's easy to titrate to heart rate. Going to the floor, I recommend converting to sub-Q prior to transferring out of the ICU or CCTC. I don't prefer people to be put on oral. I know that seems to be a go-to, but it's not, it doesn't make it any easier for looking at opioid agonist therapy or decision-making moving forward. But the interesting thing is that usually my experience, when you switch to sub-Q, the dose you need is a dose reduction from the Q1H. I'm sure there's lots of physiological reasons for this, but my experience is, even in palliative care, has been this way, that the Q1H dose is higher than the Q3H dose. And my experience has been about a 20% dose reduction, sometimes even more. So people can be on fairly high doses, but when we do switch to Q3, I always have a Q1H PRN, but when we switch to Q3, it does not have to be an exact dose as the Q1. And as a matter of fact, I would be recommending dose reducing. I would also be saying that everyone should be offered opioid agonist therapy before initiating oral opiates in the hospital when possible. And then a decision can be made about whether they should be immediate release or long acting. It's always important to consider the exit strategy, what you're going to do at discharge. That doesn't always affect the ICU, but it certainly affects the teams. Just a comment about analgesic management. When people are on opioid agonist therapy, it is not intended to be part of their analgesia. So when some people can be on a fairly, 100 milligrams of methadone, and then people are anxious about giving them anything else for pain relief. But in fact, all studies show that they're going to need at least as much and possibly higher doses of opiates to achieve the same amount of analgesic relief. And leaving people in pain is significantly more likely to cause relapse than adding a short-term opiate within a hospital setting for a new acute pain, so trauma, surgery. But the methadone itself isn't contributing to their analgesia, and neither is the Suboxone. So yes, when we divide Suboxone or methadone in chronic pain world, they are used for chronic pain, but that's not how they're being used in this population. They are specifically being used as opioid agonist therapy. I don't think there's a benefit to divide them for people on opioid agonist therapy. And even if you divide them, it does not change that that's still a background amount that they were already on and shouldn't be considered part of their analgesia. And if they're divided, there's always a risk that they won't get their full once-a-day dose when they leave hospital. So I wouldn't be recommending dividing the doses unless there is really a good medical reason to. When people are on Suboxone or methadone, there is a very low risk that any amount of opioid you're going to add to get analgesia is going to cause toxicity more than it would for any patient that is in non-opioid agonist therapy. Sometimes people do get discharged from the ICU into the community, and that's when it's really important. If they've been on methadone or Suboxone, it has to be organized. And Friday afternoon is a challenging time. I think medical teams pick that day on a regular basis. But patients need to have evidence of their last witnessed dose of methadone or Suboxone. Many of the opioid agonist clinics are not open 7 days a week. There is none in London that are open on Sunday. One of the methadone clinics is only open Tuesday, Wednesday, Thursday. So patients may need a bridging script of methadone or Suboxone at the time of discharge. Suboxone can be ordered by anybody, although as I would, unfortunately, if you do a prescription for Suboxone on our computer, it will automatically generate 30 days. It should be daily witnessed and not 30. I haven't been able to change that with pharmacy and therapeutics either. And methadone discharging from the hospital, even if people are on carries, I generally send them home with daily witnessed until they see their prescriber in the community. I can provide bridging scripts. I think Dr. Emily Newell is going to have her methadone exemption soon. There are a few psychiatrists at Vic that might be able to do this. Right now, I'm the only one at London Health Sciences Center with a methadone exemption that can do this. So I just need a heads up if I do need to write a bridging script. For people leaving against medical advice, if they're on methadone or Suboxone, that's the only time I will give a prescription. If they're on opioids in the hospital, I generally don't, but if they're on methadone or Suboxone, I'd actually prefer to give them a script if I'm aware. That's not always possible. People can choose 3 o'clock in the morning to leave, but at least they need to have documentation of when their last witnessed dose was, so they can take that documentation to their prescriber in the community. I think that although there are things that you can do in the hospital, like you can put people up to their home dose of methadone. That's allowed by our hospital policy. You can't increase it above the home dose, but you can put it on their home dose. But as I've mentioned, sometimes home dose isn't the right dose. It can be too high, it can be too low. So I highly recommend considering when people come in on methadone or Suboxone, involving a physician in the hospital with methadone prescribing and buprenorphine training. It is specialized. I hope that from what I'm saying, you can kind of get a feel that there's different, the approach needs to be individualized, but it certainly is a specialty that I think complements what you're doing in the ICU. The other thing I thought I'd mention, because I'm not sure if people are aware of this, we did a study looking at all of the different modalities of treatment for someone with particularly tricuspid valve endocarditis at London Health Sciences Center, and the treatment that had the most effect on reducing mortality was a referral to an addiction specialist within the hospital with a 72% decrease in mortality. This was a high, I think surgery was third. So this was a higher reduction in mortality, if I'm saying that correctly. So more efficacious to refer to an addiction specialist than to start people on intravenous antibiotics. And I just think it's really important to include that as part of the regular care plan when we're seeing people with infections related to their injection drug use. The other thing I just mentioned is I have heard at times people have said that they talk to the patient and they don't want to see a quote addiction specialist. Usually when they think of addiction specialist, they're thinking about somebody in counseling. I use the term withdrawal management specialist. Sometimes I'll even talk about methadone or Suboxone specialist. Once I meet people, they tend to want to be seen by someone with that specialty. And I think as I say, if somebody's on methadone or Suboxone, it's like if somebody had MMSA, and they can't really refuse infectious disease consult. I highly recommend that people get seen by someone with opioid agonist therapy training. Thank you.
Thank you very much, Dr. Koivu. That was extremely helpful. I'm going to stop recording.